Great. Now I only see on the list one attendee so far. Is that correct, or am I missing something? Oh, no, we have two.
Yeah, I think people are just joining
Yeah.
slowly.
Okay, great, great. Maybe I'm gonna make the decision to give a couple more minutes just so that Dr. Brown and Dr. Marcus don't feel lonely.
Yeah, we had about 30 people registered as of this
Beth, can
morning.
you start the slideshow so the slide gets bigger?
Yeah, the presenter view. Yeah.
Oh, sorry.
It's pretty much the beginning of summer for everybody, right? I wonder if it's a heavy vacation time.
Yeah, especially on such a hot day. People need to be on the water if they can.
Click on the slideshow.
My
Click
wife
on
went
s-
surfing yesterday and
Beth.
said that like the combination of heat and water was glorious.
Click on slideshow in the menu.
Yeah, at the bottom, at the little bar there.
There we go. Thank you.
Oh, great. All right. Well, we should get started. We have four now. So we have a relatively small group today, but that's fine. I mean, we'll give clinical conversations to one person, if we need to. But here we go, and hopefully more people will come soon. And welcome to our June clinical conversation session. My name's Barry Sarvet. I'm a child psychiatrist and the medical director for MCPAP. And we have a really nice presentation to share with you today, and I'll introduce our speaker in a moment. But just start with a little bit of housekeeping. The next session of clinical conversations is on September 23rd. Which is the fourth Tuesday of September. We always take the summer off. Not that we are on vacation, but we're sort of doing other work over the summers. And so just housekeeping, we have CME as usual, and we have the code which you can see on the screen. If you are on the phone, the CME code is QOHNAB. As always, we will have the slides up on the website, and we'll have a link to for people to stream it. So feel free to share this with your colleagues in your practice and let them know if you recommend it. And at the very end, as always, we would really appreciate feedback with the survey, and also for you to share ideas for topics, for next year. This year we spent a lot of time going over and updating some of our clinical practice guidelines for sort of basic, sort of categories of information. And next year we're going to be doing a lot more kind of, sort of things that are potentially more sort of obscure, not obscure. All of it's going to be practical, but just things that are special topics, we have in mind. But our curriculum for next year is in the works. We don't have the topic for September yet pinned down, but that's the perfect time for you to pitch ideas, for topics. And we have a lot of good sort of starting points as far as speakers and other people for the program. So our speaker for today is our own Dr. Corey Meyer. And Dr. Meyer is a longstanding member of our MCPAP team. He's been working as a child and adolescent psychiatrist at North Shore Medical Center ever since he finished his fellowship in child psychiatry at Mass General and McLean Hospital on combined program. He is board certified in general psychiatry, and he did his general training at the Cambridge Health Alliance. And he is a graduate at University of Cincinnati College of Medicine. He has special interests in substance use disorders and our topic for today, as well as on working with patients who have traumatic brain injury. Our topic today is post-traumatic stress disorder and developmental trauma. And with that, I will pass it over to Dr. Meyer. Look forward to hearing what he has to say.
Hello. So I'm Corey Meyer. All that stuff that Barry said is true. Well, let me start the show here. Let's see here. I have to remember how to do this. All right. I've already forgotten. Here we go. All right. Do you see the slides?
Yes.
Excellent. So this is my talk. I did my adult training at Cambridge Health Alliance, where it was the therapy I learned was a lot of Freudian psychodynamic therapy and attachment therapy. And so I definitely, and we had a lot of patients who had a lot of struggles and a lot of trauma. I also worked in a house of correction where at one of these slides we'll talk about that people with trauma have a much higher history of incarceration, and everybody I met there had childhood trauma of some sort. So when I think about people, I always at all of my patients, I always want to know about the home environment. I want to know about attachment, and especially early life. And so when I'm talking about that, I'm going to be thinking about it through that lens, right? There's like the classic, almost like like wartime PTSD of sort of like this one life-altering event. And then there is more the childhood trauma that we tend to deal with, which is more the repetitive traumas and attachment struggles, which look different. And I think for the people that I evaluate with MCPAP, that's a common issue for a lot of them. It can look like a lot of different things. And so that's what we're going to be talking about. I got a good number of slides. I'm not going to, some of them are just diagnostic criteria and stuff. So I'm not going to read off every point of all of them. And I'm going to be trying to sprinkle in a lot of my own experience and thoughts on how I talk to patients and evaluate things, because I think that will probably be the most helpful for you guys. But obviously, like, send questions, and Barry said that he would let me know, because I'm not used to Teams enough that I even see where those are. So anyway, I'll start. This is my first slide, and there's my name, and that's a bunch of kids, some of which look happy, and that kid on the left looks so bored. Anyway, all right, how do I go forward? The mouse. All right, here's my disclosures. Basically none, but if you've got any ideas for me, I'm always looking. Objectives. So review the effects of trauma and PTSD, talk about evaluation of it, and then treatment. No, wrong button. All right, I cannot use the keyboard. All right, I got a couple of definitions of trauma. Here, this is from the Substance Abuse and Mental Health Association. So individual trauma results from an event or series of events that is experienced as physically or emotionally harmful. Oh, I have to move this little window here. There we go. That has lasting effects. That's generally that's about the definition I go with. When I ask a patient if they've had trauma and they ask me what that is, I'll say something that happened to you that was really horrible, that affected you for months after. That's my quick definition for people. And then this is the DSM definition, which gives a little more detail, and you can either directly experience it, you can witness it occur to others, or if it's someone really close to you, just hearing about it can be enough. Experiencing repeated extreme exposure of the event. So that was added with with traumatic events, school shootings and stuff, where it's on the news over and over again. When I was in training, we talked about the fact that, like, as a psychiatrist, as a therapist, when you hear traumatic stories over and over again, you can develop PTSD from that, basically. So yeah. So here's a list of traumatic experiences. Um, I know these are going to be surprising. One of the things I would say is that it's well, there's a couple of things. One, nowadays, the idea of something traumatic it's, as I'm sure, if you work with kids, I have a lot of teenagers that will come in and will tell me about the trauma they had of having their phone taken away as a consequence. That is not a trauma. So the word is used by some people relatively lightly. However, there are things that aren't. So the idea of emotional abuse and neglect, I was just reading a study that was talking about oh, I sent it out. What was the exact I can't remember. The point that there's a number of studies showing that emotional abuse, which can include a variety of things, including terrible neglect, but also chronic emotional invalidation as a child by a caregiver. Those have long-lasting impacts. So you can see chronic issues for people that have of emotional abuse that is equal to or worse than physical or sexual abuse. And so I think that that isn't at the top of our list when we think about things. But again, going back to the idea of attachment, I'm going to talk about attachment a little bit later in more detail, but it's a powerful thing. When you're a child and your sense of who you are and whether you're lovable is based on how you're treated by your parents, like emotional abuse and neglect are they have an effect, a large one. All right, types of childhood trauma. We have discrete events. We have complex trauma, which is generally almost the environment. It's a series of repeated traumas. So that's living chronically in an abusive home or relationship. And then we have the studies that refer to adverse childhood events, which are basically lists of potentially traumatic events. And there's some studies on those, and basically that's a term really to show things that have an impact on people physically and psychologically in the long term that happen in childhood. I gotta stop hitting my keyboard. If you didn't hear me the first time, the keyboard does not advance slides, just so you guys know. All right, childhood development. So here's some attachment stuff. So attachment theory is basically the idea that you develop a strong bond or attachment to your primary caregivers. And the goal is that they create a safe and secure environment. So the idea is you're a baby, you come into this world, everything is new and crazy. And I always wonder, there's a lot in the brain and stuff, and about how when you experience things over and over again, you build like a template for it. And so like as a baby where you've never seen anything, like just looking at the world must be like psychedelic, where everything is brand new and it's got to be crazy. Anyway, I speak tangentially a lot, by the way, if you have not noticed. So attachment theory is this idea that as a baby, you come into the world and you don't know anything, and your parents and caregivers, that environment is the goal of that is to be, so it's a scary world. And the goal of that is to be safe and secure for you to learn the world is safe and secure from which you can venture out and explore things. So if you come into a world that's scary and shouting and nothing is predictable, that's what you learn the world is. And that, when that starts as an infant, when this is the most important, there's a lot of research showing that the first year of life, hugely important for attachment and other things. I've seen a handful of patients in my career that are like Russian and Romanian orphanage children, and they tend to have struggles, really, really bad struggles. An internal working model is more language. This is the idea that you kind of you experience your parents and you internalize like a model of them in your head, and that helps shape your, as well as other things. And that starts, as a little kid, starts like creating beliefs about the world, about who you are and where you fit and your value. And are other people reliable? Is the world predictable? Is the world safe? This is almost one of the goals in therapy. I was in therapy for a long time, and I developed an internal working model of my therapist. So I would get into a situation, I would think, what my therapist would say about this, and that's part of the idea. And so we have attachment styles. that is that's the research, attachment research back in the 70s and 80s and stuff, where they would have stranger tests for little kids. That's showing that like attachment style is how you attach to other people, how you develop relationships with others. And there's a lot of research showing that gets established as a child with your parents and then goes on for the rest of your life. And it's if you have a disorganized attachment style, the primary way that you change that is by treatment and figuring it out and changing it. And if you don't, there you are. And emotional regulation, your ability to regulate yourself starts when you're young. Again, if the world is a scary, strange place, like it's hard to regulate yourself. And also your parents. I think it's the next slide here. Yeah. So children mimic their parents' response to stress. If your parents are really good at handling stress, you learn those skills. If your parents shout and scream every time they get stressed, that's what you learn. They also learn how to regulate themselves by anticipating their caregivers' responses. So again, if your parents are unpredictable, this is very common in homes where parents have substance use or drink, where you never know which parent is coming home, and you have no idea whether they're going to give you a hug or scream at you for asking for, a snack. It makes it hard to regulate yourself. And then I'm just saying that again, predictive environments. Some of the things they allow is to develop a sense of cause and effect. Again, if the same thing you do gives a different effect every day, that actually you struggle to realize that cause and effect. Like to create those models in your brain, and trusting yourself and your feelings. And then this last point, when you're overwhelmed and your parents are the source of it, it really becomes a struggle to learn how to modulate your own state of arousal and emotions, and you have difficulty processing, integrating, and categorizing situations. And there's a lot out there about, people talk a lot about dissociation, and that's the ability to integrate multiple sources of information at the same time. And this is one of the main ways that people struggle with that. When you get to high level dissociative disorders, the thing that is it's about 90 to 95% chance that person has a history of trauma, especially as a child. All right, I don't have a clock here, so there we go. Okay, impacts of trauma. So the younger you are, the more pervasive across all aspects, and the worse. And there's significant associations with global developmental delays, often being diagnosed with multiple disorders. The older, the more kind of circumscribed it is, and generally the better that you do. Oh, did I go two or no? All right. Figuring out my mouse now. The keyboard doesn't work and my mouse is not my favorite. Impacts of trauma. So here's the common psychiatric comorbidity, especially with little kids: separation anxiety, oppositional defiant disorder, a lot of anxieties and specific phobias, PTSD, and ADHD. All right, impacts of trauma into adolescence and adulthood, very common: substance use, borderline and antisocial personality disorder. I would say that often women tend to go the borderline personality disorder way, and men more antisocial personality disorder. I'm not. My guess would be a lot of that is just social, how culture and how people are, what we learn. And then you have a variety of things that are associated with trauma: eating disorders, dissociative disorders, panic attacks. Which for a lot of people, when you have a panic attack for 5 days, I don't personally count that as a panic attack. That is a chronic, emotionally dysregulated state, which I would say there's overlap there. Mood and affective disorders, intermittent explosive disorder, somatoform. A lot of people with a lot of physical complaints and struggles that testing doesn't show any distinct thing. That's a more common in people with trauma. All right, the ACE study, adverse childhood experiences, much higher relationship in adults with depression, suicide attempts, alcohol and substance use, sexual promiscuity, and STDs, and that often plays a role later in worrying about hypersexuality and mania, whereas that is a very common thing that you see in people with trauma and that develop personality disorders as adults. Domestic violence, physical inactivity, and all of the, basically most of the major chronic medical diseases. So complex trauma, again, that is repetitive chronic histories of trauma. That's what I said there, the first line. Read what I said in the first line. Often interpersonal, generally family and home environment, often early life onset, and within caregiving systems. All right, impacts of complex trauma. Pervasive effects on brain development. Tends to interfere with neurobiological development capacity to integrate sensory, emotional, and cognitive information into a cohesive whole. Increased use of medical, correctional, social, and mental health services. Again, like I said, I worked in a house of correction. That was people that were incarcerated generally for like 2 to 5 years. And all of them, everyone that came to see me for any psychiatric reason, they all had childhood trauma. It was really, and a lot of them, I did not really talked about it much. And they did not want to talk to me about it, but they would at least answer my questions. Yes. You know, there's a lot of, like, we talk about biological evidence and stuff, right? You know, personality disorders are thought of as really, back. Well, it doesn't matter. That's the next slide. I'll start. You can read ahead. So the personality disorders, there's a lot of biological evidence of changes and differences between people with borderline personality disorder than not. And I think, you know, when I was in training, we had the 5 axes, and you had the axis 2, which was personality disorders, which I think created this sort of like less real feeling of those disorders. And it's, I mean, that's garbage, you know, like they're very real things. People are very strongly impacted for the rest of their lives. And it's just, you know, and well, I guess also, you know, like axis 2 is also like intellectual disability, which obviously is a very real thing. But anyway, I felt like that certainly insurance saw those things as like second-class citizens. So I think that affected the field and still does. All right, impact of complex trauma, struggles with emotional regulation, developing a sense of self, poor insight into the trauma and emotions, and then alterations in states of consciousness, depersonalization. So that's not feeling like you're real. And then there's derealization, which is times of feeling like the world isn't real. And that's a really distressing thing that people experience. That's one of the diagnostic criteria of panic attacks. So at high levels of anxiety, you can get that where you don't feel real. And people have a hard time describing that. Nowadays with TikTok, the teens are getting a lot better at it. They're coming in telling me they have depersonalization disorder, and sometimes they're correct. Anyway, you know, one of the things, I'm going to make this point later too, but you know, I guess overall, I see, again, I'm talking a lot about attachment disorder, personality disorder, and other things. Trauma and early attachment, if you look at the diagnostic criteria and the way that people are affected, and you take that in childhood, you know, borderline personality disorder is, now I could admit, all right. Sorry, that's someone popped up. It was a lovely chime. So
Or you can ignore those. We'll take care of it.
Okay. I'm not good at ignoring, but I will do my best. So anyway, you know, if you look at the diagnostic criteria of PTSD, and we're going to get to this later, and attachment disorder and borderline personality disorder, huge overlap. I mean, my personal conceptualization, and I have reasons for this, I'll mention, are that really that like complex trauma and attachment disorder become borderline personality disorder once you pass that 18-year-old mark, especially if you've not had a lot of treatment for it, or at least if it was severe enough. I can click the button and it moves forward. All right, that is way easier. All right, other impacts. Uncertainty about the reliability and predictability of others. Again, if you grow up in a home and where the world is unpredictable and unreliable, that's what you learn the world is, right? Like and hopefully you have other people in your life, and school helps you to learn, okay, maybe there's some gray to this. But, you know, one of the struggles is seeing in black and white. And it, you know, when you live the experience that I cannot rely on people and things aren't predictable, that's how you see the world. People with trauma tend to struggle. I always ask people, my patients, how are they with trusting others? You know, and a lot of these questions, if you ask them directly, people will give you a direct answer. And the answer is they struggle with it. You know, I have a lot of people with trauma that can be very superficially friendly, but do not form like strong relationships. They don't let people in. They don't trust, and they'll answer that. Poor sense of cause and effect. One of the ideas is that without kind of, again, predictability, like without a sense of understanding the world or feeling like you know what's going to happen, everything can be experienced as potentially threatening. And especially kids tend to communicate their struggle through reenactments. That's a really powerful thing you can see with play therapy. Little kids will take the characters and be like, you didn't take out the dishes, bam, bam, bam. And like the play therapy is a very powerful thing where you can see exactly what's happening at home, come out. All right, differential diagnosis: adjustment disorder, acute stress disorder, PTSD. Now this is where I'm not gonna read through the diagnostic criteria, but I'm gonna talk about each of these as we go through and just give a sense of them and my thoughts on kind of ideas of it. Adjustment disorder. So adjustment disorder is basically where you have a major change or event and it leads to significant struggles. Obviously younger. A lot of times younger stuff is a lot more behavioral, and as you get older, it's more kind of emotional, but obviously that's not, it really depends on the person, but it's a huge one here is a divorce, right? Parental divorce. Kids really struggle. They struggle with being more emotional, more behavioral issues, a lot of stuff. And the diagnostic criteria is do not persist more than 6 months past the conclusion of the stressor. Divorce is not one day here and done, right? Like that, depending on the family, that can sometimes be a really long time. And moves, right? Like, a move is a little more, if moving is kind of getting adjusted to your home, a lot of the reality of adjustment disorder is that sometimes the stressor, it lasts for a decent period of time. Acute stress disorder. So basically, acute stress disorder is very similar to PTSD, but the idea is it's within the first month and then it mostly resolves. And then we've got PTSD. Oh, that wasn't seamless. So I wanted the first line of PTSD to say more than a month, but it's the last criteria. So I just messed that one up. Anyway, PTSD. So here's the first, it is symptoms are a month or longer. And generally the idea for a lot of people with PTSD is unless you get treatment, they persist at some level for sometimes ever. So PTSD, trauma and experience of it. Intrusive symptoms. So this is going to be intrusive thoughts or memories or feelings or emotions related to the event with often, sometimes out of nowhere, but a lot of times being triggered by things. And that can be the whole range of I feel the way did I just hear something? No, okay. Feeling the way I felt or feeling nothing, dissociative reactions. Yeah, dreams and nightmares. I ask all my patients, I start all my questions around trauma more general. And has anything bad happened? And then I try to let them lead the way. So with dreams and stuff, I say, do you ever have really bad dreams? And, yes. All right. Is it stuff that's happened or is it random stuff? And then stuff that happened. And I especially in a first appointment and stuff, I try not to dive in too deep, because it's you really have to develop trust in order to find out this information, but also for people to talk about it. And in the end, like as long as I know they're having bad dreams most nights about bad things that happen to them, more information that is not really necessary for my initial for initial stuff. All right, avoidance or negative alterations. So avoidance of things that are reminders, negative alterations, basically the symptoms of depression. So increased negative emotional states, which can be irritability and anger, lack of pleasure, anhedonia, socially withdrawn, less expression of positive emotions. The reality is that most of the symptoms, basically all the symptoms of major depressive disorder and generalized anxiety disorder are within PTSD. And there's one of them. Alterations in arousal reactivity, irritability, angry outbursts, hypervigilance, which is just being more aware of things. So I like to think that people are sort of like, if your normal resting state is calm and you're okay, like you take that and set it up a level. So people with PTSD are kind of always on edge. Their state of arousal is a bit higher. They're always edgy, irritable. They're always kind of aware of stuff. And that's the big thing I talk about people with sleep. If you're always on edge, you don't sleep so good, right? Like if even while sleeping, there's kind of a state of cortisol going and hyperarousal, you tend to wake up a lot easily and not sleep well. And that's a really common issue. And there's the greater than 1 month. Failed me, but now I found success. All right, reactive attachment disorder. I diagnose this a lot. It seems like this is sort of, certainly I almost have never seen this in neuropsych testing in the last 10 years or so. This is a very real thing. And this is where you have a major disrupted attachment, which oddly enough is like, let's go down. The C the diagnostic criteria, which I find strange. That should be A usually, right? But social neglect or deprivation, repeated changes of primary caregivers, rearing in unusual settings. These are the kids that are in foster care, parents that struggle with substances in and out. Another place for this is parents with significant psychiatric issues or medical issues who are hospitalized for long times. We have parents that are hospitalized for months at a time. That, especially if it happened with some sort of scary event like a suicide attempt or a parent, being found down, that can be both probably traumatic, but also is enough as a period of disrupted attachment. So a lot of times you see with these kids is that inhibited emotional withdrawal. They don't, when they're upset, they don't seek comfort from parents. And if parents try to comfort them, they get upset. These kids, they certainly don't like positive comments, but they want to be left alone. They do not want you to, and that's really hard for parents. A lot of parents don't quite get it and will cause stress by seeking that out. Social emotional disturbance, minimal emotional responsiveness to others, limited positive affect, unexplained irritable sadness, and also another big one is explosive outbursts. That's not a diagnostic criteria, but it's certainly part of it. I mean, it's part of the reactive part. And so I'll tell you that again, nowadays with neuropsych testing, I don't see this a lot. What I do believe is that autism has replaced this in a lot of ways. So a lot of kids with attachment disorders, they really struggle socially. They don't again, like we talked about early on, your way of learning how to communicate and stuff is your parents and your families and those primary caregivers. And so when those are difficult and unpredictable, you struggle. A lot of kids with attachment disorders do not make eye contact. They don't respond to cues appropriately. And so a lot of these kids have the primary emotional struggles, social issues. They have a lot of emotional stuff. They tend to be rigid. They don't have as much the repetitive, restricted stuff of autism. So I have a lot of kids who have, with clear attachment disorder, that get diagnosed by neuropsych with autism that I don't think have autism. So that's something to be aware of. With autism, when they get that diagnosis, though, they get additional support. So it's hard to. I don't fight against that a lot because it's like, all right, more help. But it's still, all right. So developmental trauma disorder. I'm not going to go a lot into this. This is not a DSM diagnosis. I do believe this is a real thing. I think if you guys are, if you're interested in this, this is something to look up. It's a diagnosis that they've basically applied to get it into the DSM, and it has been turned down over and over again. And you can actually look at their proposed criteria. And at the beginning, they've done a very good job. At the beginning, it was very psychoanalytic. It was really, anyway, almost abstract ideas. And they've really done a good job of making it more like DSM, where you could do a checklist and actually have a consistency in diagnosis. What I would say, my general take of this is that this is really, the idea of developmental trauma disorder is really complex trauma from a young age and how that affects you. So there's a big overlap, I would say, again, with into adulthood borderline personality disorder. But here you've got a lot of symptoms of inability to modulate extreme affect states. You'll see prolonged tantrums or freezing and not moving. You'll see struggles with bodily functions, sleeping, eating, elimination, overreactivity to sound. Again, that can be consistent. That can be called part of what's thought to be disorganization during routines. Autism. I'll tell you that with attachment, if someone is struggling with body fluids are always part of it. In our clinic here, whenever someone does something really gross in the bathroom, it's an attachment kid, or maybe intellectual disability. But attachment, for some reason, it's control. So there are a few things you can control in life, but what you do, what goes in your mouth and what comes out, that's that's an individual's control. So, and sleep. I can't tell. The biggest sleep issues I've had are kids with really bad attachment and trauma. And generally, it's that they don't want to sleep or they're afraid of it. And they won't even be, and I'll always ask, are they having bad dreams? And a lot of times they won't even be comfortable enough. It will take years for them to open up that they're even having bad dreams. But usually a very general, do you have bad dreams? They will say yes. But anyway, diminished awareness of emotions and bodily states, dissociation, poor ability to recognize or even describe your own emotions. Let's see here. So self-harm, struggles reacting to and interpreting perceived threats. We'll keep going. Now here's a lot of the depressive symptoms. Intense preoccupation with safety of caregiver. So again, separation anxiety is common in little kids with trauma and attachment, and also fear of something bad happening to a parent. That's a really common theme that you'll see. Something bad happening to a parent or someone that's close to them, especially if there's been domestic violence and there's something bad has happened. But you'll see a lot of that. Kids they won't let parents leave the room in the house. Oddly enough, a lot of times they'll be able to go to school, but once they get home from school, like the parent has to be in the same room or floor as them. And it's often this fear of like something bad happening. Persistent distrust, lack of reciprocity in relationships. Again, another autism symptom. All right, we're going to keep going. What time is it? All right. And then functional impairments, school, family, peer group, legal issues, health. Yeah, again, I think this is at the very least, if you read about it, this is helpful for a lot of things that are, again, this I would say explains a lot of diagnoses of bipolar disorder in kids with trauma and attachment. It's like, I think the diagnostic criteria of these proposed criteria, I think kind of describe a lot of that very well. So other disorders, these are, so there's a big overlap with anxiety disorders. What the anxiety you tend to see in kids with trauma history, intrusive levels of worry, especially about something bad happening to people or themselves. A lot of somatic symptoms, again, with attachment, a lot of bowel issues and stuff like that, a lot of constipation, misperception of situations as overly threatening, and an urge to avoid, so a lot of school refusal. Depressive disorders, again, if you look at PTSD, all of these symptoms are part of PTSD. So you get a lot of irritability, sadness, difficulty enjoying things, hopelessness, guilt, and these other struggles, especially sleep. Sleep is a huge issue in trauma, and really a lot of things. All right, again, things that are misdiagnosed this way. Autism, so you want to look at the early history. Again, a lot of kids are born into these environments, so sometimes that isn't as helpful, but it can be. The social skills are different with different people. That's, the idea of like autism is that across the board they struggle socially. It's not that simple, especially with how wide the spectrum of autism is, but that can certainly tell you something. ADHD, the time course of the symptoms. I'll tell you, I think I go into this a little bit, but the ADHD, I see it for a lot of kids with trauma. They can present exactly as ADHD, just constantly all over the place and not focusing on anything, and not necessarily things that trigger them, or just because they're so crazy anxious. But I'm saying this based on I've had kids with that in the office. You would swear of ADHD, the way they interact, and they get neuropsych testing, and it says not consistent with ADHD. And so I'll be surprised by that, but I've seen that enough times. And then bipolar disorder. True bipolar disorder is rare before adolescence. This is a controversial thing. I personally don't really believe in pediatric bipolar disorder. I agree with this, that really severe bipolar disorder is going to start at maybe like 12 or 13, and that's going to be usually kids on an inpatient psychiatric unit. And really, again, the primary thing here is episodic, which bipolar disorder is, versus a persistent pattern of how you manage emotions and interact with people. That is more trauma and and substance and other things. All right, what time I have to go faster. All right, so how to assess. So this is one of the things that, and I didn't say this. The MCPAP website is great, and if you go through and there's 4 providers and you can look for this diagnosis, and there's a number of different things there, including these algorithms and the CATS scale for assessing symptoms. I think it's a really good resource. It's well done, and you should definitely check it out. And there's a few pages of clinical pearls. It's a little dense, but they're good. So this is this is on the website, and so first thing is that you screen for trauma. I always ask about home environment. I always ask about emotional validation, and the question I ask is, do you feel like your emotions matter to your family, especially to your parents? And I've asked this of people that were adults, like when you were growing up, did you ever? And hell no, and so like the answers you get will tell you so much. But that, do you feel like your emotions matter? And that is, there was a study I remember reading, and it said that for borderline personality disorder, trauma is like 90 to 94% of people. And then what explains that other percent? And they found that if you ask that question, do you feel that your emotions mattered? That was like 100% consistent. So I would put that in the camp of neglect or emotional abuse or something, right? But chronic emotional invalidation. People learn you don't matter. Your emotions don't matter. You don't matter. And in abuse, people learn you're not good enough to be loved by me. So anyway, and the other thing I ask about in conflict is conflict management. Like I'll ask the kid in front of the parent, like, all right, when you get upset, what happens? Do your parents stay calm? And then I'll ask the parent, when you get upset, what happens for you? Because the parents will come in and they'll tell you all about how their kid is screaming and shouting and destroying the world. And they leave out the fact that they're screaming and shouting right back and telling them that they're a little, whatever, and again, that's another question. When I directly ask that, people will tell you the truth a lot of times, or at least give you an answer that will be surprising. So I always ask, when your kid is acting that way, how do you manage that? And that will tell you a lot. And the goal isn't to create shame, it's to put it out there and to make it something that you can then talk about and work on. So the child and adolescent trauma screen, I'm going to get to that in a second. That's those questionnaires that are, I believe, meant for primary care. And then obviously there's always safety, filing a 51A, the sending to the emergency department. So here's this is for 7 to 17. There's forms that go down, I believe there's 3 to 7 as well. And so this is, the first page here is questionnaires of, have you experienced these things? Yes or no? And then the next one is scoring symptoms on a scale. And this is lovely. I really like this. I think this is something that should absolutely, these are, if you're not using these, I would strongly consider it. I wasn't well aware of these, and I might start using them because I really, there's a couple of things that I think are really helpful to have questionnaires about, especially when they're very uncomfortable things. I use the for OCD symptoms, for a lot of them, very disturbing, intrusive thoughts. I use it for that, and I like this for that too. It can be very intense to answer these questions in person, but easier, in a less intense way. So evaluating symptoms. All right, let's see here. Again, assess the full spectrum, really just depressive symptoms, anxiety, a lot of that stuff. That's really, what I'm talking about there. With kids, higher, separation anxiety, fear of something bad happening to the family. Outbursts are very common. Adolescents, much higher rates of self-injury and substance use. And of course, substance use can look like everything. This is a whole nother talk, but I have definitely found that significant cannabis use in teenagers can look like everything, including a lot of those kids are diagnosed with bipolar disorder because they get so irritable and angry, although it's a persistent thing, from cannabis. And I believe that's both the relationship with parents changes, but also like cannabis does that to teenagers. All right. So you want to talk about the impact on family and kids and their function, as well as, and that's especially for families where the trauma is not coming from the family, but is affecting everybody. Or, the really, well, I mean, all of these are very sad, but, stuff where it's like the family learns that the uncle was abusing the kid. And that obviously plays out in a lot of difficult ways. And then assessing their needs and current supports. How to respond to disclosures when you're in the room. Like it's important to create a safe environment and help them to feel calm. Don't push too hard. Validation and empathy is really important. Following the reactions as you're asking questions to see, again, like I make a point to like get information that is necessary and not push hard for information that isn't necessary. Like if this is just the screening, just to find out that the thing is there, it can be helpful to find out. I will always ask something like, is this someone, close to you? Is this someone that you see every day? And that's really more for assessing safety. So I go far enough to feel like that the kid is to know whether they're safe at home or not, and so they're like, but I always start very broad and then get more specific. Is this happening in the home? Is this someone in your family? When's the last time this happened? And yeah. And when you can and when it's appropriate, separate interviews. Sometimes it's if it's a parent, that can be really hard to do, and that might not even be the. If there's, if you're filing a 51A, maybe at that point it's not the time to do that if you're going to file that anyway. But, if a parent is doing the abuse, obviously you would want a separate interview, but a lot of times those parents are not going to allow that. The other thing is going to be kids that they, what you want to maintain safety, and they might not feel safe talking about this on their own. All right. And then, concern of sexual abuse in young kids. There are children's advocacy centers, and if you Google that, you will find them. And they can do evaluations, including forensic evals of kids. What is this now? Objectives, treatment. Look at this. I'll probably even finish maybe. All right. So do your best to one of the major goals is to try to make homes safe and give them a safe community. That gets really tricky depending on where the trauma is coming from and from whom, but you need to do your best to do that. Some would say that until you can establish safety, that really that's the first step. And if you don't do that, therapy is a lot less likely to succeed. In the long term, so you want individual safety, and part of that is developing competence. So the idea there, that's is developing competence in things and activities, to develop self-worth and say, I can do this thing. And so things that you enjoy, to feel a mastery of something, can be a really powerful thing, especially if you feel worthless and powerless. Pay a lot of attention to the body, a lot of integration of things, so just integrating physical senses with emotions and other things are really powerful. Grounding techniques are especially for dissociation. But it's part of dissociation is if something horrible is happening to your body, the brain knows all right, that's not me. I am separate. I'm over here, and that's just and that's just happening to the body. And that's part of the idea behind dissociation is in order to survive, you separate, and they're not together. And that can be a really challenging thing to reunite. And also, especially for younger people, but traumatic reenactments. And that's going to be, like reenacting sexual trauma onto someone else or violent trauma onto somebody else. All right, therapy. There's a number of different types of therapy that have evidence. The big three, and this depends on kid versus adult and where you find, but trauma-focused CBT for individuals, cognitive processing therapy, prolonged exposure, those have the best evidence. EMDR is a very interesting one. And, I was researching this for this talk, and what I learned in training was there's a question of how important the eye movement aspect is, and that is still a question. But there's a lot of people that certainly find it helpful. The question is which components of it are the most helpful. Narrative exposure therapy, and then there's the family and group stuff. So a variety of different forms of child-parent therapies, attachment regulation. For significant attachment issues, there's the Attachment Institute, which is in Worcester. I've had a number of families go there. Very intense. Not everyone finds it helpful. A lot of people struggle to manage it. I mean, when you're dealing with therapy with trauma is very hard. It's the one thing in the world you don't even want to acknowledge ever happened or exists. And the point is to figure out how to acknowledge that it exists and happen, and in safe ways. And it's really, really hard. And so it's with therapy. It's really, it's as best you can. It's important to find someone who has trauma experience. And the link at the bottom is an option to find that. Medications. So I believe so there are 2 medications FDA approved for PTSD. That is sertraline and paroxetine, but not in children. Sertraline is FDA approved in children. Paroxetine is not. So the SSRIs and SNRIs. So when you look into this, primarily for adults, sertraline, paroxetine, fluoxetine, and venlafaxine all have they all have evidence supporting their use in PTSD. It's not as impressive as we would like it to be, but it's there. And that's primarily with negative alterations of cognition, so mood. Let's see here. Alpha agonists. This is going to be the clonidine, prazosin, and guanfacine, especially helpful for trouble falling asleep, states of hyperarousal, and nightmares. I use a lot of prazosin. And I've had some people really find it necessary. So you have some people. So there's nightmares, and then there's vivid dreams. And so having vivid, re-experiencing nightmares, where basically you go to sleep, and it is like the thing happened again, and then you wake up, and it is fully in your memory, like it just happened, and that's happening 4 days a week. You're not going to have a good next day. I mean, I've had people where prazosin stopping the nightmares has changed their lives, like in a significant way. And this is something I think we don't talk about enough and doesn't come up enough, but it's huge. And it really affects people a lot. I mean, it's like experiencing it again every single night, and you wake up remembering it. And as an aside, just for people with really vivid dreams, I found prazosin helpful for that. If they're not necessarily PTSD, but some people just they struggle with that. You don't want to overlap alpha agonists. The evidence for them is not as good as we would like it to be. There was a giant, it was mostly with veterans of prazosin that found that it wasn't effective. So there's mixed evidence. I find them helpful, certainly depending on the individual. So going back to that CATS eval, this is a follow-up questionnaire. I believe I was reading it's like every 4 months, or at least the 4-month follow-up. So I think it's really good helpful. And here are some resources. This is for you, and this is for parents. And that's it.
All right. Wow, Corey, perfect timing. We actually have another 6 minutes for questions, and we only have a small audience today, but let's open it up and see if anyone has any questions. I see Dr. Forkey's here, and she has a great deal of expertise around childhood trauma. I don't know if there's any parts of the presentation, Heather, that you wanted to ask about or comment on. And actually, since the group is so small, feel free to just unmute yourself and ask a question, just for a couple moments. Maybe people are already transitioning back to their clinics, I guess. Oh, it says mics are disconnected. Maybe we have to unmute you.
I think people have to raise their hand for me to unmute.
I just unmuted Dr.
Oh, perfect.
Forkey. Yeah, yeah.
Can you guys hear me?
Yes.
So thank you so much. That was so useful as a kind of great overview of sort of what we think about. And I really appreciated it. I think the medications are really interesting given the issue related to the fact that, as you pointed out, the SSRIs and SSNRIs are tested in and have efficacy in adults, but not in children. Do you have an age at which you will start to use them or not use them?
I don't use paroxetine, so there, as far as that one goes, it's effective, but it has more side effects and drug interactions. So I generally will go with. I use a lot of sertraline. It's the overlap with PTSD and trauma and anxiety and depression. I always struggle with how much of am I giving 3 diagnoses for one real, right? But I mean, you can pretty much every kid with PTSD, you can diagnose with generalized anxiety disorder or major depressive disorder pretty easily. And so I'm likely gonna, for those symptoms, especially if it's bad enough, I'm probably going to be trying sertraline, kind of regardless, like so for those symptoms to see, and so that's and then also we've got the alpha agonists are FDA approved for ADHD, and so often that's comorbid. But it's I will have that conversation with parents as far as age. So for SSRIs, they're FDA approved down pretty low, and so I'm not as nervous about. I mean, actually, all of those are for ADHD and then for depression and anxiety. So yeah, I if they have a lot of those symptoms and they're struggling enough, I'll try.
Great, thank you.
Thank you, Heather. Other questions? I guess, that Corey's talking about, in a way, like we're talking about, sort of the use of, FDA approved medications, for a different indication, from what it was approved for. But you make the good point that, this construct of PTSD in childhood is, it's definitely not a clean sort of construct, and we don't find the PTSD diagnosis as useful and applicable. A lot of the patients that we treat, who have trauma-related disorders, it might be more appropriate to think of them as having a mood disorder, but also keeping in mind that the underlying, cause of that, is likely to be, predominantly related to the trauma. But in any case,
so Barry, do you guys then really think of this differently, that it's like an environmentally caused mood disorder versus, biologically, a child who's biologically vulnerable that way? Like, is that how you think of it?
Well, maybe sometimes. I think it's kind of like, in just personally, I think of it as kind of different for different kids, that there's some, and it's very speculative too, in terms of, trying to assign causal, sort of mechanisms, to these things. But, in certain cases, it does seem that there's sort of a lot of evidence for it to be, environmental, especially when there's an absence of any family history and other kinds of, sort of factors that make us think that there's kind of a constitutional deficit or underlying, cause that's outside of the trauma. But, it is very speculative, I would say. I think we should remind ourselves that, according to the DSM-5, and not that the DSM-5 is the be all and end all. And actually, I was going to reinforce the point that Corey made about developmental trauma disorder, even though it's not official. It's a very useful way of thinking, and if you review the criteria for developmental trauma disorder, even though it's not official, it really does help you sort of recognize, what we mean, by complex trauma. And so whether it's called a DSM-5 diagnosis or not, maybe that doesn't matter so much. But I guess the point about, diagnosis is that things like depression and GAD, if sort of they're thought to be related to something else, like a reaction to trauma, a psychological reaction, then exclusively, again, and all this is speculative, then they wouldn't necessarily qualify, for it, because a lot of the DSM-5 diagnoses have exclusions that if it's caused by something else, or if the symptoms can be attributed to something else, really that's kind of the more accurate phraseology, that that excludes the diagnosis, and it prioritizes the diagnosis for which the symptoms are considered to be primary. Anyway, is there another question in the chat? No. And we are over time. So I am going to end the session. Thank you so much, everyone, and especially Dr. Meyer for the great presentation, very thought-provoking and helpful. And I hope everyone has a nice summer. I hope we're all safe this summer, and I hope to see everybody and more back on September 23rd after our break. Thanks again.